Our next speaker, Dr. Shukla, and he's going to come and share some of that experience with us. So we're very fortunate to have him on our MIBEC team, and welcome.
Thank you. What I wanted to do is talk a little bit about this work that you've been hearing a lot about, the India experience. And you might wonder, like, we're sitting here in Milwaukee. It's nice that you go to India, you do all this work, great, great, great. But, what really is the benefit? I mean, why should you care sitting here in Milwaukee today? And I hope to make an argument why, in a way. Well, one, there's a critical gap, and, there is a need, right? And we all care about the world. And I know everyone sitting here, in medical schools I'm at the University of Pennsylvania, Dana and I, at the medical school, they've done surveys, and almost 70% of the medical students coming in want to do some global work. So it's common now that we want to try to address the need. We want to, but you could talk about, well, I mean, there's a lot of need in North Philadelphia. I mean, why are we going all over the world? It is true. I mean, but there are lessons that we learn when we do work in Africa, when we do work in Asia, where the need is so great, where communities are affected by economic issues. There are parallels, of course, and so it's not one or the other. But it is true that in the world today, there's a critical gap in the expenditure for surgery. A lot of things, a lot of attention went into HIV, goes into malaria, goes into TB, a lot of diseases, and it's very important. But the surgery expenditure is so low that it's a crying need. Why is it such a disparity in what resources are being expended in the world? And so what that does is it creates a huge need for what we call the burden of disease. The surgical burden of disease is extreme around the world. And for a long time, it hasn't really been on the World Health Organization's agenda. It's been really focused on medical diseases and infectious diseases and other things. But it has now come to the fore that the amount, so there is a lot more attention that is now coming to it. As we speak, so much of that need is unmet. More than 75% of the need is unmet. And so, yes, these are children. These are kids around the world. They're just like kids in the room here today. And, if we can do something in some way, if we have that capacity, can we create models to sort of alleviate that burden of disease? And so, this is something that we've been focused on. And now rare diseases. When you go to talk about it, as important as exstrophy is to everybody in this room, none more than you all as parents of children with exstrophy, in the end, somebody's going to say it's 1 in 50,000. I mean, how much resources can you put into a rare disease? You're helping maybe a small number of people when, if I give here, I can help a large number of people. But the reality is that rare diseases are increasing. Exstrophy is just one manifestation of rare diseases that are increasing around the world for various different reasons. And a lot of it is we're fortunate to live in a developed world, even despite all the problems we still have with pollution and endocrine disruptors that are in the environment that none of us can avoid. But they're that much more heightened in the developing world. Pesticides, the plastics, pharmaceuticals that get into the water, poorly treated fertilizers that get into the water supply. And so all of these things are sort of creating the environment where we now have more rare diseases. So coming to exstrophy, that you all know in the world here so well, and as surgeons, as surgeons, we try to think 360 with this, and we're learning more and more to think about the other patient-reported outcomes and your perspectives. We're trying to include them much more. But for us, what we really want is that, Dr. Pippi Saleh spoke about different phases of your life. And for us, these are sort of the phases that in the beginning, we want to give a good, secure closure. But we want to do it in a way that it doesn't affect the kidneys. You probably experienced it. If you do it too tight, you can get hydronephrosis. If you get infections, you can get kidney damage. You can get infections. We want to achieve urinary continence, but again, not at the cost of hurting the kidneys. We don't want to make a child dry, make the bladder neck very tight. Hey, you're dry, but what's happening to the kidneys and the upper tracts and all of that? We want them to have a functional and normal genitalia. And we want someday for them to have normal sexual function and fertility. And there's sort of a challenge out there. We call it the Ransley Challenge. Dr. Ransley, Mr. Ransley, as they call it in England, was the chair of urology, pediatric urology at Great Ormond Street, one of the distinguished, prestigious children's hospitals. And he sort of issued this challenge once. He said, after a career that I've spent treating, he's retired now, he still comes to the meetings, he's in his 80s. He said, I did exstrophy for 50 years. Show me one child who voids normally through the urethra, is dry day and night, can have normal ejaculation and normal sexual function. He says, I just don't know that this is achievable. And this was sort of the gauntlet that he threw. And he said, can you do this? So surgeons around the world have sort of taken this and said, I think we can. What has changed? What can we do between when Mr. Ransley retired and where we are today? Can we change it? Now, I've talked to him again. He's like, well, that wasn't quite how I said it, and maybe you misheard me, but you get the point. You heard him, right? So, and it was, sometimes the British have a style of being provocative, and it was sort of to create a discussion to say that we have a long way to go in exstrophy, and can we really get there, and how are we going to get there? But then there is the reality that exstrophy is a rare disease in the United States, right? So, you can see the numbers. I can't quite read the slides, but you can see that, if you look at the total number of patients born, we're thinking about 1 in 50,000. And how many live births are there in the United States every year? Anyone know? How many babies are born in America every year? It's a little more. It's about 4.2 million, but maybe it's 3.5 million today. It is dropping, so you might, Dr. Reiner might have the most recent numbers, but it's around 4 million-ish per year. That number in India is 22 million a year. So something that's 1 in 50,000 becomes that much more common in countries with high birth rates. And I know India pretty well, but sub-Saharan Africa has an even higher birth rate right now. Not in pure numbers, because India is just a big country, but the birth rate is higher there. It's lower in the developing world for sure. And we know, one thing that we know is that as urologists, that volume makes surgeons better. The more you do of stone surgery, prostate surgery, the common things that we do in urological care. And this has been looked at, they've studied cardiac surgery, surgeons who do bypasses or heart transplants. The more you do, the better you get. It kind of, makes sense, but there's actually data. They've actually done the studies to see that, hospitals that do more exstrophy repairs have lesser complications, less devastating complications, because, I didn't put the pictures here because you all have seen these, but these can be devastating problems. If you take on exstrophy and you're not very experienced, you can make it a lot worse than if you just don't fix the exstrophy. And so we take that as a very important, and it frightens a lot, I'll be quite honest with you, frightens a lot of pediatric urologists that I don't know if I want to take on exstrophy because if something goes wrong, it could go really wrong. And so how do you get better? And how do you increase your volume? So, this sort of took us on a journey of, not that we wanted to get better by going and operating on kids around the world and practicing by any means, because there are models that sort of, and these are really good models, but I don't think that slide came out right, but there are a lot of models where you go and you operate in other countries. There are organizations that, you'll fly to, I don't know, Ulaanbaatar, Mongolia this year. Next year, you're in Dominican Republic. The following year, you're in Haiti. The following year, you're in, Ghana. And these are great, experiences. You're really helping people when you do surgeries that do not have devastating complications. It's okay to do those, hypospadias, hernias, big hydrocele, various things, stones. You're not going to hopefully cause devastating complications. But can you do exstrophy like that? Can I do exstrophy 1 year here and then not show up ever again because, my team is going here next year? And of course, Dr. Pipisale mentioned the whole, to teach, give them a fish or teach them to fish and they feed for a lifetime. How do we teach? And can you teach exstrophy in one trip? And so we really felt like if we were going to make some difference in exstrophy and augment the experience, MIBEC, that Dr. Krieger talked about, that's happening here. That's an experience that is increasing our collective experience. Because when Dr. Krieger does an exstrophy repair, I'm virtually or in person in the room. So I did one exstrophy, next week he does one, now I've got two. Now, I might not have done the one in Wisconsin, but I was there thinking it through with him. And so my experience just doubled. And so that's why MIBEC has been doubling, tripling, quadrupling our experience, because it's not just something that, when I trained as a fellow at CHOP, we did 3 exstrophy repairs the entire year. I came out of there not really knowing how to do exstrophy. I needed somebody to teach me if I was going to do one. And the children, it was so sparse. I spent a few years in Minneapolis. I didn't see any for 4 years. And then I saw, a couple that would, that came in. And so if you're in that situation, how can you really be good? So how can I really help children, or how can all of us help the kids to really say that we're going to do better, that we want to really specialize in this, that we want to commit ourselves to exstrophy? And so we came up on this collaboration model that said that, and this all started, and then we didn't just come up with it. These things start organically, but, in the interest of time, you've heard pieces of that story here today from, Pam and, Dr. Saleh and others, Rachel, who have been on the India workshop. So it started, Dr. Grady and I were invited to a hospital in Ahmedabad, India, where a surgeon that we'd met through a different network, crazy, but my mom and dad were on a trip in Malaysia, on an Indian family, sort of Indian tour guide trip with another couple that ended up on the trip, their age. Oh, my son's a pediatric urologist. Oh, my son-in-law's a pediatric urologist. Where? In Ahmedabad. So they connected us, and we got talking, and he said, we got a lot of exstrophy here. Why don't you come? And I've also called Rich Grady. And I was like, thank God, because I'll come, but I was a really young guy then. This was, young guy. This was 2008 when we had the conversation and said, why don't you come to Ahmedabad and kind of see what you can do? So we showed up to that hospital, and we were just stunned because we had never, to that point, seen so many children with exstrophy in various states of disrepair. Most of them had opened up. Most of them were secondary repairs, all brought in at once and said, hey, what can you do? And we were like, whoa, and what can you do in a week, really? So we tried our best. Each surgery, as you know, takes the entire day. You have 15 children there. There's 2 of us. And there's 5 days of surgery that we had allotted, so that's 10 kids that we could help at most. So 5 weren't even going to get help, and the 10 we helped, somebody's got to take care of them afterwards, and the team there had no real idea because they never took care of exstrophy. And so we committed to a long-term model that day. Rich and I talked afterwards, said, do you think we can go back? What do you think? I'm not doing this without you, Rich, because you have a lot of experience, and I'm going to learn from you as I do this and hopefully grow our experience. I was in Minneapolis at the time. And so there's a lot of things that go into it. You need a host institution. So we found that this hospital had what it takes. It is the second largest hospital in Asia. It has almost 3,000 beds. And the pediatric surgeons are doing over 17,000 operations a year. It was a massive number. And they were committed. They're like, if you'll come, we'll do it. We'll bring the patients back. Because we said, that day that we can't do it unless the patients are going to be back next year. They said, we'll bring them back. It started that way, and each year we sort of committed to building it. And I was just so fortunate that, And I'll tell you this, initially when we started doing this, some people would call and say, hey, I've got time next year in January. Can I come on your trip? I really want to get some extra-fees under my belt. We said, oh, that's not what this is. This is not that you go to India to practice so you can bring that here. We said, this is a commitment. This is every year. This is a long-term deal. And we really want surgeons like Pippi Saleh, like Doug Canning. Oh, you see in the picture there. Doug, Pippi, Paul Mergurian from Seattle joined after Rich's unfortunate illness. And Dana Weiss and Pramod Reddy, who's the chief at Cincinnati Children's, ended up joining a few years. So each joined a few years later, and then we had a cohort of surgeons. And we don't change that cohort, we add to it. But after somebody's been on this trip 5 years, then they sort of get into the surgeons cohort. But we wanted to really protect our kids in India and make sure that what we're doing is not just I don't want to use the word a mission trip, because it's not just a mission trip. We're not going there just to do a bunch of cases. And help people. That's what you do on a mission trip. I'm not putting it down. But this has become so much more. This is a endeavor of really learning about exstrophy, about doing a large volume that is making us better surgeons so we can help a child in Philadelphia that much better. And what we learn in Philadelphia each year now makes a child in Ahmedabad that much luckier, because now we've just, we're getting this bi-directional experience. This worked really well. Let's take this year. This worked really well. Let's incorporate this into our surgery. I saw Dr. Saleh do this in Ahmedabad. Let's do this in Philadelphia. He hears our perspective, and everyone gets better from it. And so the other thing we said is every patient has to come back every year. And so you can see that we basically closed that hospital, the children's ward, and these are all children with exstrophy who get admitted. They're all in a bed. Their parents sleep right with them on the bed. These are in private rooms. This is a big ward. And all the children have exstrophy, and they all go through what your children go through. They get a cystoscopy, they get a VCUG, they get a ultrasound, of course. Many get urodynamics, and many get a DMSA renal scan. And we get all of the data, and then we discuss it all. This is some of the post-surgical pictures. And what was very important to me is what we were doing there should be of the same quality of what the data should be the same quality that we have in MIBEC. So we are very careful about data collection. This was older data. This is almost a 7-year-old paper that we published. And it was important to me that it was published, and we showed that our rates of dehiscence were now almost the same that we have in the US. So they went from about a 70% dehiscence rate. They would do it and it would pop back open the next day. We got it down to basically 0, just by instituting a lot of the same protocols that we use here. Continence is around the same. About 25% we're voiding per urethra. We're hoping that'll go up to 40%. Dana showed all of that data. And we've been really following these children with a hands-off approach, just like MIBEC. We don't go to, we try, as long as the bladders are safe, to try to go without, an augment or bladder neck closure. Now, many kids will get it. I'm not saying that's a wrong operation, but trying to see, can we manage to get past age 5, age 6, even if they're having incontinence. And the families are on board. They're saying, this is what we do in the US. Okay, well then we'll go with this here, where there's no reason we can't do it if other people are going through this, people are experiencing this. And we published some of that data in JAMA, which is, an important journal, to say this is legitimate. What we're doing there is not just, when I first started doing this and you talked about it, like, yeah, it's all your India data. I mean, who even knows what happened to that child next year? Do they even come back? It's really nice you went and did all this surgery. But what happened to them? Do you even know? And, most global surgical work sometimes is very hard. People disappear. They go back into the villages, in rural areas, and they don't have access. But they, our partners, Dr. Rakesh Joshi, Dr. Jayshree, our partners there, make sure they would send cards, they would send texts. They would send, you need bus money, you need a train ticket. You're coming here. You're coming back here for follow-up. It's just a commitment up front when people join this. And so that really led to us to have, we published about a 76% follow-up rate, which is better than almost any global surgical model. So we were really able to get the kids in and see them year over year. And so we've been publishing a lot on that. We have a lot of research projects ongoing, and I won't bother you with that. But a big part, Dr. Pam mentioned that, is, while we're operating, we have a research team that's meeting with the families as you talk to them, really going through, the mental health inventory of the families, depression inventories, all types of patient-reported outcomes, and continence. And, how do you feel about this? And, how is this affecting your life? In what ways? And we have measurable questionnaires, validated questionnaires that we're using. How did COVID affect you? How did that affect your access during those 2 years? What did you do during those 2 years to get care? So really trying to understand the impact that this work has. Geneticists, as Louisa Pyle in the middle there, she's at DC National, Washington National in Washington, DC. We have one of the largest non-European cohorts of children with bladder exstrophy, and we have the DNA and the RNA sequences. So to understand between these cohorts, European and these, are there differences in that can help us target what gene is responsible, if that is even possible, because it seems to be epiphenomenal, and it seems to be a lot of environmental impacts. It's not just a gene that we can just find and understand, but there are contributing regions, variants that can, contribute to that. Caregiver distress, and this is what a typical day would look like. Lots of surgery. Here's a child from the Bahamas. I get a lot of calls in Philadelphia. Can we do this child from the Bahamas? It's just down the Bahamas. It's an hour's flight. But to try to get an exstrophy done, and we ask our hospital every year, can we do some charity surgery? It's nice to do charity surgery, but the hospital says an exstrophy charity means, surgery for 12 hours, an ICU for a couple days potentially, and then a whole, couple weeks of clinic space or of a hospital room, orthopedics. It's you're asking for $1 million, right? Whenever you ask for that. And so we've been telling the families, come to India. The same team will take care of you, and we can get the same results. It's a long way to go, but we'll get you there. And that's where Pam comes in, and ABC comes in. And I just hand the patient over, and I say, can you make this happen? And then I don't, I just can't, right? I mean, you have so much bandwidth in your life, and that's where Pam and her team take over. And somehow that kid suddenly is sitting there in Ahmedabad, from Africa, from Turkmenistan, from the Bahamas, from Haiti. We've had children from all over the world. Iran, several children from Iran have come to us in India for Dr. Saleh to be there, myself to be there, Dana and others, and get the same care that we just couldn't give them here because our hospital can only do so much charity care. You can see this is an older slide, it's about 2 years old, but we've done now, I think we're sitting at about 135 exstrophy repairs and a large number of epispadias repairs. Cloacal exstrophy is very difficult. It's not the surgery that's a problem, it's a nutrition. You're going to hear about cloacal exstrophy, which is a really complex situation because you have the bowel management issues and absorption, and a small baby born with cloacal exstrophy needing total TPN. It's not possible at a public hospital, and sadly it has a high mortality rate. We want to try to improve on that. We're working on different techniques, but it remains a major challenge. And this is what I mean by volume. This also is a 2-year-old slide, and I don't think I have the Boston numbers, so Ted, don't look at that number too much. Remember, these are old numbers. But what I'm trying to make a point on this slide is, a lot of pediatric urologists, if you ask them, how many exstrophies have you done, sir or madam? You're going to get a number of, okay, I've got about 12. I've done about, 10. I have done 5. We can say with MIBEC and India that I've been sort of in the room on 350 extra-fee repairs. So you've been thinking about this. It's in your dreams. It's in your thoughts and everything you're doing. You're thinking about bladder exstrophy. But that's the only way it happens. It's by collaboration. It's by this international collaboration, and it's by MIBEC, by investing those resources. And that 350 has made Dr. Krieger a better surgeon. It's made me a better surgeon. Dr. Saleh's already there, but maybe it's even made him a little better surgeon. So it's made Dr. Weiss, Dr. Groth, all of us better surgeons by working together. And that's what I want to show to you, that what we've done is impacting your care. You don't maybe know it, but in every way we're thinking about your child. When you come into the room and you have a question, well, we've dealt with that question in January for 2 weeks. We solidly dealt with it, and we've dealt with it in all of our MIBEC conferences that we have monthly, and we've dealt with it in our extra-fee clinics. And so it just, and we're still not perfect, as you know. I don't think anyone here is going to say their child is perfect because of extra-fee. Extra-fee is a journey, but we're on this journey, and we're investing in it, and we're thinking about it, and I want you to know that I think some of the best minds in pediatric urology are really committed to it. It's a rare disease, but it's everything to us. Because also what he said, that this is a fundamental problem. If you can understand extra-fee, you understand almost everything in pediatric urology. It's a global anomaly that just poses such a major challenge that it affects every bit of pediatric urology that we've learned over the years. And this is a picture we do with all of our patients, and what I want you to see in this picture, these are all the patients and their family members. And what's happening in the background is where Pam and Rachel and all of our Janet, all of our ABC team is really spending that time with the children. And it becomes like what you're doing here. It becomes a picnic. We're not able to do a MIBEC, event potentially over there. Like this, a conference, but we want to, and we're going to work on it. Pam and I are talking about it, but the kids are enjoying. They have the same games they're playing. They're doing beach balls back there. They're doing, magic shows and, so many things that I hear about, puppet show, and the kids are smiling and they're laughing, and it makes them want to come back. How do you make these families that are day laborers, that are getting paid, and so when they're there, they're not making any money because they're paid by the day. How do you get them to be here? And all of these children are receiving free care, entirely free, not a single thing is charged, and not a day in the hospital, no food, none of that is charged because it's a public hospital and the government is very supportive of this endeavor. But you still have to think about these things, and extra-fee affects the poverty-stricken families. And there's a very simple reason. Those who get prenatal care and see extra-fee, if they see it, they tend to terminate the pregnancy because they worry that we have no insurance. There isn't a great insurance system. How am I going to pay for a lifetime of surgery for my child? And so what happens is that those who don't afford prenatal care, they're the ones who have the children with extra-fee, and now they're already poor, and now they have a very complex disorder with a very expensive days ahead of them. And so that really brings that empathy and that feeling of, and they're so committed to their children, right? We love our children the same around the world. And they're there, and putting everything in your hands and asking you to do the best you can for these children. And what can we do to give them the same life that we hope we can give here? And so it's been a learning curve, interest of time, I've got 1 minute left. And so a lot of these things we've gotten better of because we go to India. And I think you might even see the Saleh flap. Yes, the Saleh flap. We got that because we went to India, the external rotation of the corpora, bladder neck tailoring. Many of the things that we now do, we do because of India. This is our team, the surgical team, and the observer team. We have several surgeons who come from all over the world to learn on this trip. And you can see them there watching on video as we operate, and then we have great discussions. And this year we already have signed up, I think, 6 surgeons from Switzerland, multiple surgeons from Moscow, Russia, Belgium, all over the world, Canada, Brazil, South America. They all come to India every year to learn about extra-fee. And we have this 1 week intensive where that's all we're doing, and we're collaborating. these are the, different care pathways that's enabled because of ABC. And there's a video, but I think just show the video maybe between sessions because I'm going to run out of time here. Or it's on YouTube. We'll give you the link. There's a nice video of the work we've done in India. So thank you for bearing with me, and thank you for supporting us to do the work here and around the world.